Welcome, everyone. Thank you for logging in for tonight's AACP webinar with good friend, dear friend, Dr. Eric Phelps. A slight change in plans, but we are going to work with what we got. Dr. Phelps, as some of you may know, has had a pretty involved year, and so he appreciates all your prayers and support. His wife actually had a heart transplant in December and is doing well, kind of working through all the nuances of the medications and stuff. And unfortunately, towards the end of last week, lost her father. And so Dr. Phelps reached out to me and said he hates to do this, but his head's not in the right space. He has all of his slides done and everything to share with the Academy, and is actually looking to get more involved with the Academy, potentially at a board level in the future, but just had to bow out for tonight. So we're making it work, though. So we have a recording of Dr. Phelps talking about these very same objectives at a symposium that was held last October. And it actually dives into a little bit more detail. And on top of that, he's going to give you access to all of his slides and stuff. We will also be fielding questions, and I will get those to Dr. Phelps and get them back to you guys. So right after we get started here with a few housekeeping items, we will play the recording of Dr. Phelps. You'll have access to it, and it's professionally shot and recorded. Audio is great, and it's awesome information, and I think you'll really find it valuable and beneficial as it hits the objectives he was going to talk about directly tonight. But we will have him back, and I think maybe the questions we get from it will help give kind of part two of this Airway report and information that he's looking at as an orthodontist for a lot of these pediatric and adult patients that we're seeing with sleep disordered breathing and craniofacial pain problems. So Dr. Eric Phelps is an orthodontist, practices in San Jose, and has been a great friend to the AACP and the likes of us. He has no conflicts of interest to disclose, and the continued education credits will be sent to you at the end of each month for the webinar series, and Shaylin and the Academy will get you that info. Upcoming events, September 13th, Dr. Jim McKee will be talking about the TM joint disc, MRIs, and how he looks at imaging in assisting his diagnostics. Dr. McKee is a phenomenal lecturer, has been around the block, works a lot with Dr. Mark Piper, has taught with him for years, is a wealth of knowledge, and just really provides good content. And if you have imaging, diagnostic, MRI type questions, you know, he's the guy. He and Dr. Piper have looked inside many joints over the years. So a lot of good content from him. And then August 11th, 12th, we have our annual symposium. We have an awesome lineup of speakers, and so we highly encourage you to get registered for that. Thursday night before, or Thursday afternoon before, there's going to be a workshop with the mentors. So we hand-curated mentors in the industry to have one-on-one time. And the way we picture that is all those questions you have after someone lectures, you go up and you privately address them and want to pick their brain. That's what this afternoon's about. So there'll be experts in the field there just to field questions and ask one-on-one, and it'll be a round table. You'll rotate around for the 4 hours of the afternoon and get some phenomenal small group time, depending on how many people sign up. Right now, we're probably 10 to an expert. So get signed up for that as well, as that's kind of a extra perk to arriving there a little bit early into San Antonio. So without further ado, Dr. Phelps is a graduate engineering major from San Luis Obispo at Polytech, and he attended UCLA dental school, and then went on to get his master's in oral biology, and then went on to orthodontics. He's got thousands of hours of continued education. He's a diplomat of the ABO. He's a diplomat of American Academy of Dental Sleep Medicine and the American Board of Craniofacial Dental Sleep Medicine. So not many orthodontists hold those titles, but he's really dedicated and committed to helping doctors, patients, and really bridging that gap with the orthodontists and the general dentists that dive into that. So what we'll do is we'll pass it over to Dr. Phelps's recording here and gather up some questions, send it on into us, He and I will review them and we'll get you some answers and probably use those questions to help develop the content for the next webinar that we can get them in on. So thank you and enjoy.
Thank you so much for being here. And Daniel, thank you for giving me the chance to share really a faith story, a faith journey. So we'll get back to Tyler later in the presentation. I took some photos on my walk over this morning, and that ray of light is going right through Coach Holtz's name. So he is here with us, and you can't help but look at that photo and know that God is with us on this journey to help kids breathe better. That's another photo that I saw walking over, and just past that main road in, I found DeBartolo Hall. Right? I am wearing a 49ers jersey. Our fan base are called the Faithful. Right? And that photo, I just had to pick one that had USC in the background with Joe Montana raising the ball up high. So that one is for Dr. Olmos, who had to leave early. And I was so impressed with Dr. Zoggy's presentation. I saw him show this kid's case, and just my heart breaks for what some of these kids go through, but it's so amazing when you see simple solutions. So I can read it up there. Nasal hygiene, myofunctional therapy, frenuloplasty, and orthodontic expansion. Relatively simple things, and changed his life and changed his parents' life, right? But then you just look at that photograph, and you really do have to step back and take it all in, because there's simple things that we often miss, and that's the point of this presentation. Sometimes you just have to give these kids a UCLA t-shirt, okay? All right. We hosted this event. We had that blessing in 2019, and some great doctors showed up, and you can see all of us just celebrating. This is a celebration. And what happens is you develop friendships in this movement that become so powerful for not only your career and helping your patients, but just your education and your moral support and going forward. Okay, so this is Valley Christian High School. When we had our meeting, we got a group of doctors together and visited the campus, this high school campus. And Dr. Doherty, the president CEO, he told me once, he said, in God's eyes, every child has infinite value. And if you approach work that way and you see a kid walk in your office and you're thinking, in God's eyes, that child has infinite value, it makes screening every patient for air obstruction very simple. So typical screening, you might have had it when you were a kid, right? Vision, hearing, scoliosis. Well, now Valley Christian is developing a protocol with Daniel's help to screen for sleep-related breathing disorders. And I think we ran through the prototype last year for all first graders. And this was the meeting, right? So there you see Daniel and Kevin Boyd. Dr. Damon was there. And there's Dr. Doherty in the front. And at that table, we were discussing how we're going to do this. And then Dr. Damon said, I'm going to help support it. And that night at the Fairmont Hotel in San Jose, he handed me a check for $25,000. So that's what we're working on. And once we get that developed, we want all schools to screen all kids for sleep-related breathing disorders. So there's my wife and I as high school. Somebody in photo, a good friend of mine, took that photograph and said, hey, I got a photograph of you and Suzanne. And we met in junior high, but we started dating in high school. Love of my life. And so a little closer up, and you think, how can he date that guy with a primary canine? All right? So you see a primary canine, and you think, oh, that's no big deal. His pediatric dentist just missed it and didn't say anything to him. He's 17 and has 2 baby teeth. But now we know, really, what does that mean, right? I have sleep apnea. I snored as a kid. Those canines were impacted because my jaw was too narrow. Who knew, right? Nobody knew. Well, we should have known, and I'll show you why. But that is God's blessing. If those canines weren't impacted, I wouldn't be here. I wouldn't have gone into orthodontics. I really owe a great debt of gratitude to Chad Harrington. Chad, are you here? Chad picked up on the importance of Airway in orthodontics. Thank you. And he introduced me to Daniel. And then he told me to go see Dr. Olmos and take his courses. And then, of course, Daniel told me to get a sleep study, severe apneic. Flew out, saw Dr. Leeper to get my nose fixed, all right? And then I started testing my breathing on a treadmill with breathe right strips and realized I had nasal valve compromise. Then Daniel said, go see Kevin, go see Ed and Lynn. And then that was at our symposium. Imagine Dr. Damon sitting with us as we're doing exams on kids. And then, of course, I took the breathing course that Ed and Lynn hosted at St. Charles. And there is a Zoom call. Imagine that, a Zoom call with Juan Moon sitting next to me at the office and Dr. Damon from Spokane discussing how to help patients breathe better. And there's me with Dr. Damon. I do like jerseys. We used to wear jerseys in the office every Wednesday. I think we called it Jersey Day. And so I'm wearing this jersey, and I'm working on this very nice young lady, and she looks up at me and she says, you know, I work for the 49ers. Do you want me to have Patrick sign that? I said, of course. Here we go. Yeah. So there it is right there. And really what we're trying to do is get to truth. And I'm pretty sure I heard Dr. Gomanak mention that word yesterday morning. She said, get to truth. And that's what we're trying to do. So there's the breathing course with Patrick McCown that Lynn and Ed hosted in St. Charles that Periodontist on the bottom right. He's awesome. But a lot of people there, and thank you, Ed and Lynn. You contribute so much to the knowledge base on Airway. Okay, so imagine inside the Baker Hotel, we're having this Airway course and breathing course, and he asks us to walk around that room, okay? Breathe out, hold, and take as many steps as you can. So I got up to 49, I was trying to beat Daniel. I got up to 49, 50, then maybe I got to 60, and then the last part he said, go ahead and now jog and do it, right? So now I'm jogging, breathe out, jog, hold my breath, I'm about to pass out, and then I'm watching the pulse oximeter, 92, 91, 90, and I got down to 88, right? But imagine some people suffocating during the night and sleep get below that. So think of how hard it was for me to get to 88 and what some people are doing to themselves in their sleep. All right, so then Daniel told me to go to the AO meeting. Who would have thought I needed Daniel to tell me to go to an orthodontic meeting, right? I went to the one in Hawaii when I was graduating UCLA because I had to take my board exam, but I may have been back to one since. But I went, and there's my friend Ryan Robinson. He happened to be there too. And look at that, we got a photograph of Dr. Guimeno. Now, Dr. Guimeno spoke at this meeting for about an hour, and a lot of it at that time was over my head. This is 2019. But I have the audio version of it, an hour. I've listened to it 5-6 times, and I'm going to be sharing clips of what he said at that meeting. So let's start with this one.
I'm very eager to talk to any orthodontist because they are the future. They are the one who own the upper airway. And once again, you know, I know that you learn about the bite, the smile. But to survive is more important.
So think about what he just said to a room full of 1,000 orthodontists from around the country, but really around the world. He's saying you can have the greatest impact on how people breathe of any medical or dental professionals. And he gave his presentation at around 9 to 10 in the morning, and he had to catch a flight, and Ryan and I luckily caught him as he was on his way to the elevator and got that photo with him. But imagine now a program director for a well-known orthodontic residency program getting up after lunch and mocking him. And having a room full of 1,000 orthodontists where maybe 500 are pro the Airway idea and concept, and half of them are thinking, this has nothing to do with us, and stop telling us what to do or how to think, right? So what happened is Dr. Guimeno, this world-famous physician who we all owe so much to, he said to the group, in Europe, I'm asked to be an expert witness. And he talked about a young boy who died in his sleep at 12 years old, and he mentioned headgear and extractions and things like that. So this program director gets up after lunch and makes the typical joke about, oh, you guys are going to be tired after lunch and fall asleep. And then he says, and who knew that headgear killed kids? I thought it was just guns. Right? So that's where we're at, and that's why we're all here, because we need to change that. And with God's help, we will. So I put in this Bible verse, and I love this. Then the Lord God formed the man from the dust of the ground. He breathed in breath of life into the man's nostrils, and the man became a living person. He doesn't say nose and mouth. He says nostrils, right? So what does Dr. Guilleminault think about that?
You are obligatory nose breather. If you mouth breathe, something is wrong.
And you saw Dr. Zaghi's slides, you see these kids mouth breathing in their sleep, something is wrong, right? So if you were in Philadelphia, you know that our diagnosis for that could be NG. It's just not good, right? Mouth breathing is not good. So Suzanne and I were blessed with twins. This is the summer after my third year of dental school at UCLA, boy and girl, Cade and Chandler. And I found this photo, and they were sleeping with their lips together then, okay? But what does Dr. Guilleminault say about premature babies? So these were, Cade and Chandler came at 33 and a half weeks, 4.1 pounds, got down to about 3.5.
77% of premature infants which are equal or below 36 weeks of gestational age are going to present obstructive sleep apnea. And that is related to the abnormal oronasofacial growth, particularly the abnormal growth of the heart palate.
We should have been taught that in dental school so that I would have been prepared, right? Because Cade just had a sleep study, and he's got apnea. And his new dog, all right, that's Rocco. I'm sure he's apneic. I ordered him a sleep study, okay? And then there's Chandler. Her first day of dental school was last month at Loma Linda. And I think that we need to get her a sleep study too at some point. I think a sleep study is good for everybody. There's our last family photograph with our youngest, Dane. Dane passed at 3.5. And you can see he has really red skin. That was Thanksgiving 2007. They told us, our doctor, I remember, this is going to be easy. You had twins, premature twins. This is going to be easy. And at about 2 months old, we saw that on his stomach. And within days, okay, we searched and never got an answer while he was alive. We knew he had something called ichthyosis. There's many forms, almost 20. All right, look what happened to his fingernails. And my friend Greg Rabbits, we went to UCLA together for residency. He treated Dane twice at the hospital for his teeth because his enamel fell apart. And there's Chandler giving Dane a bath. There is no greater joy as a parent than to see one of your kids taking care of the other. And you can see how bony his shoulder is. It took thousands of calories for him to replace a skin it shed twice a day. We couldn't help him gain weight. And then we put Aquaphor all over his skin to give him a little bit of a moisture barrier. And there he is in the fire truck bed. Chandler would sit there and entertain him before he went to bed. And when he fell asleep, he would scratch. And he would itch himself with those fingernails. And Suzanne would go grab him, and there'd be blood in his sheets. So she would hold him all night. She did that for years. So in loving memory of Dane, he's part of this faith journey, right? So we did charity concerts. This is a website we formed, Dane's Friends for FIRST. So FIRST is a great organization that helps families with ichthyosis. Foundation for ichthyosis and related skin types. So Sons of Serendip came out one year, which was great. And the turning point for us was we rented the Flint Center, which is near on the De Anza campus. And for those of you that follow Apple, you know that the Flint Center is where they hold a lot of their events. So God bless Chandler with a dancing ability and bless Cade with a guitar skill. So we decided to do these charity concerts and have our kids involved. And that's Kyle, a young man with ichthyosis that we met through FIRST. Notice the jersey.
When I was in second grade, we did a project called Flat Stanley. And for that project, we would send a paper doll around to different places, and then we would get information and pictures back about where he went.
So to raise awareness for FIRST, we decided to find a real doll, and with the help of FIRST, we sent him around the NFL. This is Tommy, the NFL's biggest little fan.
Chandler and I filmed that 9-10 years ago, and it's crazy that now she's starting dental school. So she's applying to dental school, and she wrote her personal statement, and she talked about Dane as an index patient. And I had not heard that term. I knew that Dane was the first person in the world diagnosed with that condition, but I didn't know the term index patient, but that's what it is. So we had rented the Flint Center, and the executive director called me and said, Eric, I need to let you know there's a corporation that wants the venue the weekend you have it. And I said, I can't move it to a different weekend because I have a young lady from Australia flying out to sing, and she has ichthyosis. Her skin condition was so bad they wanted to amputate her feet. So imagine she flies from New Zealand with her boyfriend. She gives this great performance at the end of our show, and I'm looking forward to congratulate her, and I can't find her. Her boyfriend took her to the hotel because her socks were filled with blood. So anyway, I told the executive director of Flint Center, I said, well, I'll try to find another venue. Could you please ask if this corporation would be willing to donate $100,000? And she said, Eric, well, this is the marketing department, and I've worked with them before. I don't think they're going to do that, but I'll ask. So they checked out our website, Dane's Friends for First, and the next morning I got a call that they were going to send me a check for $100,000. I should have asked for more, obviously. What it was and what I sensed, it was Apple. And the iPhone 6 release got delayed a couple weeks, and it flowed over into our time slot. So we sent $50,000 to Yale. They sequenced Dane's DNA that they had biopsied. They had a skin biopsy, maybe 4 months before he passed. So Dr. Choate got the biopsy from UCSF, sequenced it, found the defect. It was a defect in the ectoderm, so it affected hair, teeth, nails, and cardiovascular. So he passed from heart failure. I'll talk more about that later. An index patient. So humbly as a dad, what does that mean, right? It's so easy to go into that woe is me phase. Why did this happen to us? And then personalize it. Why did this happen to me? But when you flip that and say, why me? Lord, why me? Why are you trusting me to be Dane's dad? Right? Why? And then it changes, right? You have friends and you get perspective. My career is supposed to be about more than straight teeth. And Dr. Damon has been saying that and saying that and saying that. And then you think, yeah, but I finally got it. And God introduced me to Chad and to Daniel. And that's why I'm here. So I'm going to replay this with the words that he's saying in French, with a French accent. And I love him for this. To boldly stand in front of a room full of 1,000 doctors in a different field and say, please take ownership.
I'm very eager to talk to any orthodontist because they are the future. They are the one who own the upper airway. And once again, you know, I know that you learn about the bite, the smile. But to survive is more important.
So these are the 5 quick categories of my presentation. It's important to look at where we were. So I just want to share a timeline of world events, just to give a perspective on what 100 years is like, 120 years. So the Titanic, World War I, World War II, the discovery of sleep apnea. I think it was 65. 2 different groups in Europe, and Dr. Kulo, at the same time, pioneered the first cure for OSA. And this is one of the cures that Dr. Clower does not offer routinely in his practice, but it's the tracheostomy. Okay, right? But that cures it. And then we landed on the moon 4 years later. So think of the technology it takes to land on the moon. But even in 65, we didn't know people were suffocating in their sleep. All right, so then the orthodontic airway timeline. I love it how Dr. Mova had mentioned Dr. Engel. I think he did. I think I remember him saying that. 1989, 1990, around there, he developed the first school of orthodontia, St. Louis, Missouri. And in 1900, they pushed for orthodontics to become the first specialty in dentistry. Okay? And then we have Dr. Engel developing expansion. So up until that time, there's a lot of crowding and people were just extracting teeth, right? And then Dr. Engel said, well, you know what, let's try to expand the arches. And then I love this paper from Dr. Boyd that he gave to me when I shadowed him. An MD in 1922, okay? And he's talking about mouth breathing. This paper was published in December, so in this December, this is exactly 100 years old. Talking about mouth breathing. Nasal breathing does not usually follow after the removal of the adenoids. You need muscle training. Talking about myofunctional therapy, right? 100 years ago, if at 4 years the breath is less than 28 millimeters, it's absolutely certain that the child will not have a normal arch unless it's aided artificially. You need to expand these kids. He's measuring with calipers, an MD, not a dentist, an MD, and saying if the arch is 28 millimeters between the lingual vein and J at 4, you need to do something. It's not going to cure itself. And then this slide, I'm not going to read the whole thing, but he's basically saying once breathing is cleared with the rhinologist, right, the ENT, then we'll send to the orthodontist. Amazing. We weren't taught this in residency, right? Treatment of malocclusion should begin as early as possible, 30 months of age being considered the most favorable time. Okay, so I'm working with Spark. Spark, thank you for supporting this event. And all of our vendors, thank you so much, because we're on this journey together, and there couldn't be a more important cause. So this is a Spark aligner case on a 3-year-old, and we're going to try to do that. My first one, and I'll let you know how that goes, okay? And then more talking about treating before age 6, right? But when orthodontics, 8 is great, 9 is fine. I used to tell patients that and parents that. When should we come see you? 8 is great, 9 is fine. No. Yeah. As long as they have perfect divine arches and they don't need treatment, yeah, no, that's perfect. Yeah, just wait till 8. So more literature. This one is, it says, the Journal for the Promotion of Orthodontia as a Science and a Specialty. 1911. Okay? Wow. And then I think Dr. Movahead would like this one, Orthodontia and Oral Surgery, and that one's, I don't know, St. Louis in 1921. That's probably in his reading list. Okay, so then Dr. Tweed came along. I'm sure a brilliant doctor. Went to Stanford, went to UC for dental school, and he became one of Dr. Engel's first students in 1927 or something like that. So imagine him as a protege, learning about expansion, specializing in orthodontia, right? And so I searched the AJODO and I found one of his publications. And what he is saying is, I'm not going to read in details, but this is all recorded, so you can go through it in detail later. But what he's saying is, I was following my mentor's treatment philosophy. I was following the expansion of Dr. Engel, and what I realized is my cases were not stable. So I started taking out teeth, because then I could get the teeth in a perfect angulation, right? And then this is what he said as his goals for stability of the orthodontic result. But there's no functional breathing or airway objective on those goals. Well, why? Well, because we didn't start learning about breathing issues until the 70s, really, okay? So when I was studying for the ABDSM, this was part of the required reading. This book was, I don't know this section, but I was going through this, and I found this information that in January of 1972, Dr. Guilleminault formally joined the Stanford group because he was recruited by Dr. Dement and Dr. Zarcone. I don't know who Dr. Zarcone is. But think of that blessing of that recruitment. Going to Europe, finding somebody, it's like the Italian group coming, right? Look what we can learn, right? Amazing. Okay, so Dr. Guilleminault in 1972. I was born in 73. Not that that matters. I'm almost 50. But this is one of my favorite articles from Dr. Guilleminault, 2005. And you have to have these articles on your desktop for you or your office manager or your treatment coordinator or however you practice to just email to the parents. Let them read it, right? But he is talking about issues related to obstructed airways in kids. Table 2 in this paper, you just say, here you go, mom and dad, take a look at table 2, and look at all the things related, and I don't have it blown up, but it's just the basic stuff. Sleep talking, night terror, bedwetting, morning headaches, ADHD, all these things are related to airway obstruction and sleep. And then look what he puts right next to it. An image of palatal expansion. How could the orthodont community mock him? He's one of our greatest advocates. He's telling us we're the ones that can help these kids the most. American Academy of Sleep Medicine founded in 1978. Sleep Medicine Incorporated, their board in 1991. And then Dr. Damon in the mid-90s with passive self-glycation starts talking about the magic of the midface and developing midfaces. Thank you, Dr. Damon. 2017, Daniel told me to read this article and give it to parents, and I did. And this was the cover we had on the medical side. So as I started talking about airway issues and sleep studies, and the pediatricians in our area were getting upset with me and calling the pediatric dentist and saying, who's this guy? What's he doing? Okay? Then I could share this with them. I'm just following what the ADA is asking us to do. Okay? Don't blame me. Yeah, the ADA is great. So you can look at this article. I don't need to go too much into depth. And then Daniel says, go listen to Dr. Guimeno. Go to the AAO winter meeting, and I did. Think about that. It took 47 years to get Dr. Guimeno in front of the AAO. That's a tragedy. Think of all the lives that could have been rescued. And it took 100 years for this article from Dr. Cohen to now, like for me to kind of understand what he was talking about, but this is lost knowledge. So we need to thank our mentors for the time they save us, because all this knowledge is out there. And Dr. Movahead, I know, thinks the same way as me, because I can tell in the way he presents. So imagine this. Years ago, Dr. Tweed was treating non-extraction, and he felt so bad about the results that he offered to retreat them with extraction. Okay? And imagine this happening with extraction cases now is what I see. All right? So this is an older patient that came to me. She has 4 bites out, but the lower teeth are crowded, really crowded. And her condyles are almost in the ear canals. That's what I see because of the muscle parafunction. See how the condyles are bent? There's so much parafunction, right? So then Dr. Damon comes along, and he says to a room full of 600 people at a forum, lots of orthodontists, lots of their team members, because the team is so critical, and you sense that with Dr. Clower's team. They're amazing. Okay? And what Dr. Damon would say is, gosh, I treated all these patients the way I was taught, and I would see them when they brought in their kids, and I was horrified at what I did to them. And so I offered to retreat them and open up space and pay for implants on many, many cases, right? So how can it be both ways? Isn't that interesting? So let's hear, maybe if you listen closely, maybe we'll hear what Dr. Guimeno thinks.
And don't pull teeth.
Teeth is French for teeth. Yeah. So Dr. Clower and I got to see Dr. Damon in Spokane when we were at the AACP meeting. And Daniel joked that we had the best chauffeur in the world, right? And we got to go visit him at his lake house. And I'm so thankful for him because he's taught me so much. Diagnosing transverse deficiency. So this is what I think is the most overlooked issue, and it's so simple to address. So when I was presenting in Dallas for the AADSM, I had to share my slides ahead of time. Carlos was there. Okay? And the person kind of organizing my section said, Eric, you really don't have that much evidence-based publications in your presentation. Right? Dr. Gomanek talked about that too. So anyhow, I went to my room that night. I was presenting the next morning, and I just hit the AJODO and just found articles. So let me share with you. You can go look at this on the video. But basically, here's the first article. And we're going to expand. I can't see without my glasses. We're going to expand, and we're going to turn once per day until overcorrection is achieved. Okay. Overcorrection to what? Right? To what? And here's the next article. And what are they going to do? They're going to turn one activation per day for 28 turns or until resolution of the crossbite. So I guess if they don't fix the crossbite, that's okay. They did at least 7 millimeters. But if we're going to do that on everybody, that doesn't make sense to me. And a third article. Expansion RP was 4-banded Hyrax, a rate of 0.5 millimeters daily. That's 2 turns a day. And we're going to do that Expansion was stopped between 14 and 21 days or until the palatal cusps of the maxillary molars were in line with the buccal cusp of the mandibular molars. And then the fourth one, expanders returned 1 or 2 times a day until the required expansion was achieved, i.e. slight overcorrection of the crossbite. Okay. And these are all great, well-intended researchers, I'm sure, and all these papers were focused on evaluating the airway changes with expansion. All great research. But the point I'm trying to make here is expand until overcorrection is achieved, 28 turns of resolution of crossbite, 28 turns of resolution of crossbite, palatal cusp of molars and mandibular molars, slight overcorrection of crossbite. Where are we going with it? This is all dental related. Expand until the upper teeth kind of match up somehow with the lower teeth, and we have to get away from that. Once you're in airway, you have to diagnose off the skeleton. You cannot diagnose off of teeth, all right? So variation in expansion protocols, that's to be expected, but there's this crossbite obsession. Forget about crossbites. Yes, we want to fix them, but we don't diagnose how much to develop the midface based on tooth position. Target for completed expansion is dental. We have to go to the skeleton. Okay, so I've been blessed to be able to have our team, we have a great team, visit with Dr. Damon. So we're on a Zoom call with Dr. Damon, and he's sharing with us a lot of things about the new bracket system, which is amazing. But here's a slide that he sent to me to share in my presentations. Okay, so when he taught me that the mandibular base is just about the same on every patient, that's when I knew that the direction was to use the mandibular base as the reference for the midface development of the nasomaxillary complex, as Dr. Boyd likes to call it. All right. So Dr. Damon also, he coined the term magic of the midface. So what he is talking about is the original arch form, what a patient walks in the door with, and the natural arch form, when the midface is developed to the proper relationship to the mandibular base. Okay, do you see it? All right. So of course, on the left, these are famous people, and they've done very well in their lives, and so this is not meant to be critical in any way. I'm just showing anatomy and the differences. So the person on the left is still in that original arch form and had ortho, and there's 4 bis out, and you see the wrinkles. Her condyles are probably overseated. She probably has nasal obstruction, right? So look at that width, and I'm putting that width at the buccal of the upper first molars, right? And look at that midface. I'm sure it is perfect. And then this width is much narrower, and if I put the exact same midface on it, right, you can see how deficient she is if you have to shrink that midface to fit within those red lines. That's where she should be. That's probably an 8 to 10 millimeter maxillary transverse deficiency, all right? And so you can say that, oh, you have a maxillary transverse deficiency, and the patient might not think that that's a big deal. But you put it in red. Okay, let's make it red, and let's put severe in front of it. You have a severe transverse deficiency. Oh gosh, well, what does that mean? Well, you probably can't breathe through your nose. Yeah, I do have trouble breathing through my nose. And you probably snore a little bit. Yeah, maybe. Have you ever had any clicking, popping jaw joint? Oh, yeah. So this is the patient that ends up in Daniel's practice. The person on the right, nope, won't be there because functional midface. Okay? So again, that's NG, right? You just tell the patient, well, this isn't good. This is not good. Okay? And they have the same mandible. If I had cone beams for those two, and I wish I did, think about Dr. Damon. Cone beam CT wasn't around. He paid to send these patients to get medical CT so he could study this. And we could study this in our offices so simply, right? But I could guarantee you their mandibles within 1 or 2 millimeters of each other, right? So what do you want? That. And if you keep it there, then you take out teeth and you have straight teeth. But if you develop the midface to that, then it's nice to have the teeth. Otherwise, you're trying to drag everything forward. Okay, so this patient walks in, and beautiful midface. This is June of 2020. I was asked to speak at the AACP that year, but it went to virtual, so I decided, we're just reopened from COVID. I decided to study every patient that I saw that month, every exam that walked in the door. I was going to study that transverse dimension. And then what does Dr. Guimeno say? I think she's got a tongue tie.
That's another short frenulum. You know, the only country where it's mandatory, and you lose your license if you don't do it, where you have to look at birth for a short frenulum is Brazil. And any neonatologist who don't check that they have looked at the frenulum as a big problem. I will tell you, every week, we have children with short frenulum. And people say a lot of things, stupid things, about how to treat that.
I love it. This was, again, at the AAO, and talking about stupid things that we do, and I've done many stupid things, and that's why we're here, to share the stupid things so that you don't do the stupid things. Okay, beautiful midface, orient the image. I'm going to go through this really quickly. I go to the mesial root of the first molar. That's the coronal section I'm going to measure the width at. You can see the apices. And she was 51, okay? I labeled the landmark. I measured the width of the maxilla at the CEJ, just at below the boning shelf there. And the reason I do that is because if you measure at the cusp tips, you get misled by tipping, right? But there is a nice spot where tipping of the teeth doesn't affect my width measurement. And so I just subtracted them, and it was 9. And I like that number. I thought 9. That's a good measurement describing the difference between the maxillary and the mandibular width. And then I drew these lines from where the IA canal is through the long axis of the lower molars, through the palatal root of the upper molars, and it went perfectly along the lateral walls of the nose and the medial wall of the orbit. And I thought, if God created us to have good support and function, that's it. That's the force vector, okay? But if you're a clencher, then you've got the buccal roots of the upper molars right through. And then that kind of made sense, the tripod roots, right? Okay, so I consider this a functional midface. We'll evaluate the tongue tie, but she is not going to end up in Daniel's practice. So then take a look at this patient. Now you can see that the primary canines are basically touching the central incisors, so there are cases that need serial extraction. There are cases that we need to have bicuspids taken out. But wait, you got to listen for Dr. G.
Don't pull teeth.
You just got to remember that, right? So look at her midface. You can't look at teeth until you've looked at the skeleton. Okay, look at her force distribution. That's not good. That's a dysfunctional midface. So same thing, same orientation. Now she's class 2. So I'm going to do one section through the mesial root of the lower first molars, right? And she's a 50. Wait a second, the last patient was 51, right? Almost the same mandible. Who told us that? Dr. D, right? Why do we have to reinvent this? He's practiced for 40 years and he's brilliant. Just listen to what he says, right? The maxilla is 44. And I'm measuring that at a coronal section further forward because she's class 2. I'm getting through the palatal root of the upper molars. Okay, so I'm comparing these side by side, and they're 5 years apart in age. So you can see the young girl who's almost 13. She's got 20 millimeters more vertical to the roof of the orbit. That green line is the same dimension. So they're 15, 16 millimeters different in maxillary width, but that blue line is the same length. They're almost the same mandible. Okay, that is a severe transverse midface deficiency. She is a -6, right? I like the +9. Okay, so that's good. And so the goal is to take that young lady and get her there. Get her up there. Now, the interesting thing is I looked at the floor of the nose, and there's a 7 millimeter difference in the nasal width, right? And that makes sense. If your maxilla is deficient, you're going to have nasal deficiency. So this young girl walks in your office. Which direction do you go? Okay? You go to a functional midface. Okay? So I ended up using 3 expanders on her to get her to 58, right? She was at 50. I wanted to get to 58, 59. I took a progress image after the second expander, the one in the middle, and I was at 52. And I said, I got to go more. So I tell Mom, you know what? I want to go more. And then you say, gosh, Eric, but look at how you tip those molars out. I might have tipped them a little bit, but look at the beginning. They're already tipped, and that's the compensation. And that's why those research papers with expand until you've reached your slight overcorrection. Well, what does that mean? I want to correct the skeletal discrepancy. Then I'll upright the teeth. That's no problem. Okay? So then we get to Dane's analysis. Once I started presenting this, I thought, I'm going to name this after Dane because now Dane works on every patient with me, right? So in June, that's our schedule, and the first patient comes in the door, and every patient that month, I oriented the images, I did the transverse, so this one was 5 millimeters deficiency with a canted mandible. She's got parafunction, probably needs a sleep study, and that's her. And then the next one comes in, and you see the low tongue posture and the cone beam, and this kid's young, right? Those are first molars that haven't erupted yet, and he's 56, That's pretty wide, right? The age doesn't matter, and I'll show you that. And his maxilla is a 50-something, 54. So he's an 8 millimeter transverse deficiency. And then you see how the tongue posture, it gets even more open towards the anterior, right? And that's what it looks like. And that's not good. That's a Darth Vader tongue. That's not good. Okay, and there he is. This kid has a breathing issue. And then what did Dr. Damon say about the class 3s? They're massive, right? So there's a class 3 at 60. And then here's another patient that walks in, this almost 17-year-old female, and that looks pretty good. I don't really have to worry about midface development because she's a +7 and she's got good force distribution and we can just straighten teeth. But this is that month. I was studying all these cases. I don't want to bore you, but all these cases, okay? And then I'm an orthodontist, I did a graph. Can you believe it? I was proud of myself. That's through Excel. Yes, that is legit. So there's the blue line measuring the width, and that's the distribution, right? So on the far right, who's on the far right? The class 3, there's 60. Who's on the far left? These are 2 middle-aged females. Those are apneic patients. Now, they didn't have sleep studies, but I'm pretty sure they're apneic. Why? Because their tongue for decades has been pushing the teeth forward, right? It's just like an extraction case. If you mesialize the molars, then you're going to get a narrow width. You're going to get a narrow part of the mandible. Now, some people just have a narrow mandible, but they were the apneic patients. So I took those out, and what do you think the average width of the mandibular base was for this group of patients in June of 2020? Any guesses? 52. 52. That's a coincidence, by the way. Maybe, maybe not. Okay, there's the kids under 7. Whoa, there's a 7-year-old, there's 6-year-olds, there's 5-year-olds, and that's what Dr. Damon told me. The age doesn't matter. That's set young. So on a 4-year-old, you know how wide the maxilla should be. It's amazing, right? So I have some takeaways. The width of the mandibular base of the first molars is set at a young age. We do not alter this dimension with treatment, right? The mandible grows back as wide as it goes back. That's set, right? The vast majority of our patients will have a mandibular width of 50 or above. With well-timed intervention and proper uprighting of lower molars, the need to extract lower bicuspids due to crowding is extremely rare. So if somebody refers to you for extraction, ask for the cone beam, do Dane's analysis, or get a sleep study. But you can't willy-nilly take out teeth until you know the midface is fully developed. Okay, so then take a look at these two, father and son. A lot of you know Ryan, right? So I don't remember how old the son was at the time of this, but let's compare father and son. Who has the wider mandibular base? His son by 1 millimeter, right? That's surprising. But Dr. Damon told us that. You just got to listen. So to prepare for this meeting, I want to do the best I could for Daniel, so I got more data. So if you look at the bottom of my spreadsheet, I looked at every exam I saw in June of this year. So you see that, right? I'm measuring mandibular base. I'm putting the patient's ID number so I can go back and study their case if I need to. But I have on the right side mandibular width and maxillary width. All right? So what do you think the average width was for all the cases I studied in June of this year? 50. God, you guys are a quick crowd. I can just go home now. I think we're done. 52.4. And then I decided I'm going to do June of 2021 also, 49 cases. The last patient was one of our awesome assistants. And her mandibular width came in there at 46. So what am I thinking? She needs a sleep study. And she's going to mess up my data, right? This has got to be 52. Otherwise, what am I even doing here, right? What do you think the average width was? So for this one, I went to 2 decimal places. 52.02, right? That's like the light shining over the stadium when I walked up going through Dr. Coach Holtz's name, right? It's a sign, right? We're on to something. Dental, facial, orthopedics, and airway develop. Okay, so now we do it. Now what do? Now we know what the width is. We evaluate transverse. Let's see what Dr. Guimeno said.
There is that concept that the apnea-hypopnea index, which I feel very guilty because I created that index, is something which should not be used anymore.
And you've heard that here. There's so much humility. Like Dr. Damon getting up in front of a room full of orthodontists and saying, I messed up these people's faces, and I don't want you to do that. Let me share with you what I learned so that you don't make those mistakes. And he's saying, I regret doing this because now all the sleep doctors are saying the AHI is less than 1 or less than 5, so they're fine, and they're not. And that's what you've heard at this meeting, right? So in our practice, we got Rhinomanometry because I wanted to study this flow limitation. I don't have much time to go into this, but it's measuring nasal breathing. Okay, but still, you have these patients that come in, and the bicuspids are touching the lateral incisors. So there's cases that you have to extract teeth.
Don't pull teeth.
Oh my God, thank you, Dr. Guimeno, I almost forgot. Thank you, Dr. G, I almost forgot. Whew. Okay, so I started treatment on her. I had cone beam at the time, but we only use it for the difficult cases, the impacted canines, right? So I got Ceph and Pano, start expansion. Dr. Damon is so talented. He would have treated this just passive self-ligation, but I use expanders. And I'm doing this treatment for her, and I'm tipping teeth.
Don't pull teeth.
It's not working. Oh, guys, don't pull teeth, but I want to pull teeth so bad. I don't want to pull teeth. The parents wanted me to pull teeth. The parents are getting frustrated because I'm not making progress. Now a bracket's breaking off, and Mom would come and sit in this chair and stare at me. Oh my gosh, every month after month. And I said, okay, that's fine. I got an option. I got 2 options. I'll give you all your money back. I'll take out the expander. I'll take out the brackets, and then I'm sure there are people in our town that will pull teeth. Or you can let me talk to Dr. Moon. He developed this skeletal expander, and I can try that for your daughter. So what did they say? They said, try it. I said, all right, right? So I hadn't given injections in probably 10 years, and my hand's shaking, and so stupid. I injected like anterior. I should have just done over the greater palatine. But anyway, I gave injections, right? I gave injections. And we get going on the expansion. Now you can see the expansion happening between those middle bars and the thicker parts on the outside. And I'm so proud of myself. And I cut off the arms because they were, I just wanted it more comfortable for her. And I knew that you could cut off the arms. So I called Dr. Moon. I said, Dr. Moon, I did it. I placed my first one, and I cut the arms off, and that's okay, right? And he said, yes, once the expansion's done. Okay, so I do pray for patients, and she went onto my prayer list. And I just kept expanding. What else am I going to do? Okay? But look what happens. Look at that. Yes. Thank you. Thank you. And this is the first one. So I don't know what to expect. But look at that. Would you ever take teeth out on that? And this is before I really understood Airway. I just met Clara as I'm going through the latter part of this case, right? Think of the benefit in her life now. She has room for her tongue. Look at the lip support. Look at that. Now, as an orthodontist, I wish I would have gotten the canines rotated and eased a lot more, right? But who cares? She can go get Invisalign for that. She can breathe now, too, right? And so then I went back and studied her case because I wasn't doing Dane's analysis. What was she? She was a 52, and I got her to 50, almost 57. I didn't go enough. Think about that, right? But I could study the imaging. We expanded. What Dr. Moon taught me is the nasomaxillary complex rotates around the frontozygomatic suture, okay? And that's what we saw. We saw expansion at the alveolar level and then some at the inferior turbinates. And so we expanded about 5 millimeters. What I want to point out here is the ratio. The inferior turbinates went about 80% of the alveolar level that I measured. In the prior case, which I didn't talk about yet, remember I did 3 expanders for her? And she went 15 at the alveolar level, and she went 5 in the nasal passage. So she went 33%. So that's the part of the treatment planning is deciding how bad the obstruction is, how old the patient is, how dense the bone is, and what type of midface development are you going to use to get the result you want, not just to get teeth to fit together and the smile to look nice, but for the nasal airway to function. And a lot of it is nasal valve driven. Okay, so this is what's happening. A psychiatrist in Hawaii became great friends with the sleep physician that I work with, and we become great friends. So patients go from Hawaii to the Bay Area for a sleep evaluation, and then Dr. Rama sends to me for a midface development, airway, TMD, what I call an airway report, right? And we're developing at our ortho practice a Center for Airway and Midface Development. And so this young lady is struggling. Now, her non-REM AHI, I think, is 0.8 or 0.9, but her REM AHI is 24, right? Or a REM sleep problem. And so don't look at teeth yet, just go to the skeleton, Dane's analysis. She has a 5 millimeter transverse deficiency, and if she has a significant airway issue, then maybe we go to 6 or 7 with our development, right? She's AP deficient.
And don't pull teeth.
And this is the challenge, right? Teeth are gone, right? She's in ortho treatment. So how do I do that? How do I walk that fine line working with an orthodontist, and we're going to collaborate, right? But imagine she's going to fly out. She's probably in flight now. I'm going to see her Monday to place a skeletal expander. And I can't mess this up. And I've messed up a bunch of them. Look at that one. Is it possible for me, dummy, to have a TAD go across the midline? It's not my fault. The lab gave it to me, right? Right? Okay, don't make that mistake. That's bad, right? Daniel with Papa Romano, right? What do you call it in golf when you want a second chance? A mulligan, please, right? Is that fun to tell your patient I need a mulligan? Let me numb you again and take this out and make a new one and stick it back in. Yeah. Well, here's another one. Imagine if you put it in and it's rotated. I don't want to change the AP position of the two halves of the maxilla, right? Mulligan. Okay. Here's another one. Is it surprising that this failed? Well, that anterior TAD's not long enough. It's not bicortical. Mulligan, right? You see them tipping. So we went back to treat him a second time with Dr. Moon's advice. We made a tandem. There's 2 expanders. So we didn't put the anterior screws because they were going to hit the roots, right? But we have 6 TADs. They're proper length. They're nicely positioned. And now we have skeletal expansion, right? So this is how we learned that.
I was just showing this case, and Dr. Barry Peterson, who is the head of Naval Medical Center. So he's treating basically all the male patients in mid-20, so older. So these are the challenging ones. So he started to adopt this tandem technique. And look at this, red, razor failure. So the first one here, 3 tries, all failed because he used a single MSC. Okay. Second one, he failed twice. Third time, he was able to split. So if you look at it here, single, tandem. When he finally tried the tandem, he was able to make it. So long story short, he basically switched over the tandem for every single patient he had in the military. So all successful here, and he used the tandem. So when he used the tandem, almost 100% success, even in these extremely difficult cases. But
So you can see the third box down, that's Dr. Harrington. And then down below is Dr. Pooja Patel, who I get to work with at our office. She's an amazing orthodontist. So I don't want to mess this one up, right? So what we are doing now is, under Dr. Moon's advice, we send our cone beam and the iTero-scan to Spain, to this Ortozon lab. They're awesome. And then they send us a digital workup. So they have STL files for the expander, so they're centered, not just what it looks to be centered, but it is centered, and they can show us where the anchors are going to be to make sure they're not on the wrong side of the midline, and then they can make sure they're long enough, because they can do cross-sections through both halves and show us, and then they send a digital file to our lab who 3D print a model, and then they can send it to me. So this one is going in tomorrow on Monday, and we have protraction hooks so that we can work on trying to advance the maxilla as well. And I'll be praying for better sleep and improved brain function. That's really what this is about. Her brain is not working well. Yes, Ed?
So with this, because of the way that the maxilla expands, it's not straight out. It's more in the front than the back.
Yeah.
Is the plan to turn those at slightly different rates, or is that not in the thought process?
Gosh, I love that. See, this is the reason why we do this, is so that we can chat about how to perfect techniques. What I see in this tandem, when we have 3 anchors on each side, it pretty much is an even split. And so we're just going to go really slowly on her because of her age. And she hasn't had prior expansion, yeah. And I'll show you. I've got one to show you. Yeah. Okay, so 2016, a similar case, severe crowding, class 3 underbite. I treated Dad, who had 4 bites out, tons of recession, like Dr. Damon said, lots of perio. And I got him a sleep study, apneic, and he came back a year later and said, I don't want my daughter to have any extractions, and I don't want her to have jaw surgery. So your hands are tight. You do the best you can. She's really class 3. We do a skeletal expander with protraction hooks, and we're moving along nicely. And then I am in the office in the afternoon, and I hear this commotion that something about Dad kept turning. And I'm on the other side of the clinic, and I'm thinking, oh gosh, if I walk over there, her eyes are going to be going sideways, and oh my gosh, I have heart issues, and stressful, right? And that's where she was at. So we just told her to turn it back, and she went to the top of my prayer list, and she comes back, this is a year later, oh my gosh, she looks beautiful. What is going on here? So then I study her case using Dane's analysis, and we had her turn it back a little too far. Amazing. We just underdevelop. Patients come to us with compromised midfaces because of all the issues that were described, and our goal is to develop it to the proper dimensions, and we're looking at teeth. I saw the teeth tipped out, and that was scary. And I don't know the ramifications of stress on other sutures, and that can be scary. All right? So now we're going to get back to Tyler. In 2019, I just did a brief intro at the meeting that we hosted, and I thank my team for that great meeting and for Daniel for trusting in us to host it. But I talked about Tyler because I had just gotten him back to the office. I treated him in phase 1, and I didn't know back then, right? So there is the Ceph, there's the tracing, class bimaxillary retrusive, there's his airway, and there's a sleep study, severe apnea. So I knew I had my work cut out for me. I was visiting Daniel. I think we were driving between Diamond Lake and his home and talking. And I told you, I said, I got Tyler back, and he is resisting any treatment. And gosh, how can I make this work? And then Daniel just, you just got to bring him in, the kid at 12, and have a heart-to-heart with him and tell him what you're trying to do for him, right? So we got him on CPAP, at least so that he could get by. Did a skeletal expander, okay? There again, there's dummy, right? So it comes from the lab. We swapped the front and back screws, right? All right, so the back one, we stopped it before it hit the pituitary gland. Well, that's good, okay? That's good. But the expansion looks great. And now look at this. Now I'm going back and studying this case because I'm presenting to you. That's how I learn, right? I didn't study this just before, like right after it happened, unfortunately. But I got quite a bit of expansion, but he has a massive mandible. I could have gone more. And this is what I was fighting in the pre-surgical ortho. I wasn't wide enough, so I do pre-surgical models, and they weren't articulating because I needed more width. We just don't go enough. Think about that, right? And then look at the details. When you're comparing images and studying, do you see where that yellow arrow is pointing? So this head is rotated left side back. So the thicker part of the zygoma is showing there on the right side of that image, right? But if you're comparing time points, you got to get that orientation set, otherwise you're comparing apples and oranges, right? So there he is, pre-surgical. We're going to do an advancement for him. Here he's done with the surgery, okay? And there's the post-surgery, still in braces, but there's the airway. Look at the difference. And then with Dr. Rama, he's outfitted our office with WashPat 1s. Can you imagine? I said, Dad, let's get a sleep study on Tyler. I send it home. I can get data in 2 days from the sleep physician. We got a cabinet full. He brought over 10 boxes of WashPat 1s. I'm like, oh, gosh, I don't want $12,000 of equipment in my office just sitting here, right? But that's how we do it now. So think about that, anxiety, depression, headaches, skipping school. And Dad told me he's now a straight A student. But I didn't want you to hear that from me. This is a 17.
Okay, hi David and Sherry.
This is a 17-minute video, but I want you to hear it from the parents. And I think that you will be enlightened.
Okay, hi David and Sherry. We first met your family at the ortho office in August of 2014, just over 8 years ago. Tyler was 8 years old. A lot has happened since then, and I appreciate you both joining me for this conversation. As an orthodontist, I'm so focused on looking at records, photographs, models, x-rays, now even sleep studies. However, while we can learn so much from records, I think we can learn more from parents. So I appreciate your time and look forward to hearing what you have to say and learning from both of you. So I'll direct this first set of questions to you, David. We treated Tyler with phase 1 orthodontics starting at age 8. And at the time, I had very little awareness of sleep-related breathing disorders, and I failed to help get Tyler diagnosed with sleep apnea. At the ages of 8, 9, 10, do you recall what Tyler's energy levels were like? How was his focus? And what about his disposition?
Yeah, so Tyler, I think around age 8, around when we started seeing you, he kind of lost a lot of his ability to, or enjoyment of high energy activities. He did sports up until about age 8. And then around age 8, he just didn't want to do them anymore. So he had played soccer and baseball. Around age 8, he stopped and we couldn't get him to really do much at all. Mm-mm. So it was, and it wasn't great. And because he just wanted to sit around. He began to want to just sit around home. Around that time, he also started gaining weight, and possibly because of the lack of exercise and energy. And he started becoming a lot more irritable and anxious. He was always kind of an anxious kid, even as a little kid, but it just started getting progressively worse. It was a real issue at home around that time. That's when it began.
Okay, thank you for that. Sherry, these next questions are for you. When Tyler returned for a phase 2 consultation for orthodontics at age 12, he mentioned he had been having headaches. I had learned that headaches in children increase the likelihood of sleep apnea 10 to 14 times. With the estimated baseline prevalence of sleep apnea in kids at 3 to 5%, that meant that the probability that Tyler had sleep apnea based on his history of headaches was around 50%. So I referred Tyler for a sleep study. What was going through your mind when I, as an orthodontist, recommended a sleep study? Did you think it was strange to be getting that from somebody in the dental community?
No, actually, I didn't think it was strange. I myself suffer from headaches and have for a very long time. And so I kind of thought that maybe Tyler had inherited it from me. Headaches run in my family. So no one had ever thought to ask me or anyone else in my family to get a sleep study. But Tyler was also in behavioral therapy at that same time because his anxiety was so high at the time. And we mentioned it to his therapist that you had recommended a sleep study. And she had said to us, I think that's a great idea because Tyler looks constantly tired to me. He's always got bags under his eyes. And no one had ever suggested anything like that before. And we thought, why not? I mean, there are so many issues related to poor sleep that we knew it couldn't hurt getting a sleep study. So, we thought that's a great idea.
Well, the other issue is that around that time, he had stopped enjoying school. He was having a real hard time getting to class in the mornings. We were having constant fights. His anxiety levels were even more off the charts by then. So the headaches were only one issue. The anxiety and the anger and lack of energy and all that stuff was all working together. And he was in therapy, not only talk therapy, but also medication. And that wasn't helping at all. Yeah. So when you said sleep study, it's like, this makes a lot of sense.
Yeah.
And we didn't know intellectually how they were connected, but it just made a lot of sense. It did take a while for us to get that sleep study in terms of months, but when we finally got it, it made a big difference.
Yeah, I see that, and it leads into my next question. And again, this was kind of directed to you, Sherry. I made the referral for the sleep study in January of 2019. The in-lab study was performed in May of 2019. And then you returned to our orthodontic practice in August of 2019 to discuss the results of the sleep study and treatment options. And I'll never forget what you told me now that you knew Tyler had severe sleep apnea. Would you mind sharing that again?
I don't remember exactly what I said, but it was so eye-opening to find out that he had such severe obstructive sleep apnea that I think I was relieved to finally know
Yeah.
that we could treat what was going on with him, and that it was treatable, that it wasn't just that our kid was broken and he had all these behavior issues, that there was a root cause and that we could do something. And I just remember feeling so relieved and so grateful that somebody like you thought in the first place, let's try this.
And that's what I remember is you saying we're so grateful that we had the sleep study and now we understand what's going on and what may be the cause of some of the issues. And then you did tell me, because it was by the time you got back to me, it was August, and you said this past school year, he was taking home from school almost half the time.
Yeah, it was more than half the time.
Oh gosh.
Yeah, out
It was
of
a tough year.
180 school days, he was home for 140 of them.
Wow. All
Because
right.
he just refused to go to school.
Some days it wasn't the whole day. He would,
No, it wasn't
Yeah,
the whole
and
day, but he would refuse.
yeah, he refused to go in the morning
Yeah.
or come home. He would come home early. Yeah, it was a tough year for him at school, and a even tougher year at home with the family.
Yeah.
The family dynamic really shifted due to his behavior or his suffering really, and the way it manifested itself at home.
Yeah, and that's and I kind of mentioned when I saw you guys, was it a week ago? I'm realizing when you treat patients like Tyler, you're treating the whole family, right? So
100%.
yeah, so back to you, David. As I presented my treatment recommendations for the second phase, which were skeletal expander, surgical advancement of the lower jaw, braces for a couple years, and then using a CPAP during the whole time so we could treat a sleep breathing issue while we're trying to get the anatomy improved, right? And you suspected there'd be pushback from Tyler, right? Because you're already treating somebody that's having sleep issues and anxiety and all those issues that go with it. So can you please describe those times and how we got through it?
I mean, I'm laughing now, but it wasn't funny at the time.
No.
Yeah, I mean, after having, lived through a really tough year, his 7th grade year, that's the year we just described, where he fought with us every single day about one thing or another, going to school, eating, whatever. And then when we knew what the solution was, a CPAP, which I knew was going to be a very big inconvenience for him. And then all of the other work that you were going to begin to do, including getting his wisdom teeth out, because we did that at the same time, but the expander, having that, in his jaw, in his the roof of his mouth. I mean, I just knew it was going to be tough because he was going to push back. I didn't know how painful it was going to be, but I knew it would be somewhat painful, and that's exactly what happened. It was the level of pain he was in, physical pain, which would manifest itself in just like mental anguish, and then he would lash out toward us. It was, every day was a new challenge, and we tried to be as empathetic as we could be, but it was very hard. And we have a daughter who lives with us, or she did at the time, and she had to live with it as well. Especially that first month was the toughest, and yeah, he almost wanted to pull. He wanted to pull the plug right at the beginning, and we actually came fairly close to pulling the plug and figuring out something else. But then you convinced us to continue with it.
I remember mentally preparing myself when Tyler would come in just to be ready to support him and encourage him. And yeah, I remember those times. And Dr. Clower was behind the scenes encouraging me too.
Yeah.
So finally, for both of you, 4 years ago, Tyler's airway was collapsing 13 times per hour during sleep. His REM sleep was terrible. REM sleep should be about 20 to 25% of the total sleep time, and Tyler was only at 2%. And you already shared the struggles he was having in school at the time. Now his airway only collapses twice per hour, and his REM sleep has normalized. He went from 2% of total sleep time to 24%. How is he doing in school? And please describe his quality of life compared to 4 years ago.
Tyler is a completely different kid. Oh my gosh. He's a junior in high school now. He is a straight A student. He's taking AP classes. He does drama and musical theater, and he has friends. The story is so long, but he went for a period of years with like no friends. He didn't leave the house. He didn't go places on weekends. He didn't call people. People didn't visit. And now he's going out on the weekends with his friends. He's got a group of guys that he regularly plays Dungeons and Dragons with. He's funny. He's smart. He's into fashion. He's got the best relationship with his older sister ever. And she used to be terrified of him because of his anxiety and his emotional outbursts. Like, she was afraid to ever talk to him. And now the two of them are thick as thieves, and she's off at college and they FaceTime each other almost daily. And it's just made such a huge, huge difference in his life. And as our family as a whole, it's just completely different now.
100%. I mean, he really is a different child now.
Yeah.
And like in terms of like focus, here's like one example of focus. Like for a long time, he would only kind of just like watch his iPad or YouTube videos or whatever. But now this Dungeons and Dragons thing that he's into, he has bought all these books. He'll spend hours creating adventures just on his own, where he'll just focus on creating this new adventure for his friends. And that's, doing schoolwork is one thing, but when you're spending hours like that focused on one task outside of schoolwork, I feel like that's a big sign of his emotional and intellectual growth as well. And he's 16 and on a great path, and it's night and not even night and day. I don't know. It's night and apples. Like, it's just completely different.
Well, I think he's on the path that God intended for him. He has a quality of life, and especially the REM sleep, his brain's able to recover.
Yeah.
And gosh, I thank you so much for sharing your personal experiences on behalf of Tyler. He was an amazing patient, and our team has been blessed by your family and your journey.
Well,
We can't thank you enough for how supportive you have been, because we don't have any other doctor who has taken such a special interest in our child through this whole process. And we wouldn't be where we are today without your kindness and your caring. So thank you so much.
it's true. I've mentioned that to Tyler. Whenever he gets kind of upset, or when he was, oh, we have to do it again, I have to go back. I always tell him, Dr. Phelps has taken a personal interest in your case, Tyler, and all he wants and all we want is for you to be happy. And there's some rocky steps along that path, but you're gonna have a long life.
We're gonna get there.
And once we get there, everything is smooth sailing. But the fact that you took the personal interest has made such a big difference in addition.
So much.
Yeah. So I don't know if you can do that with all your patients. Maybe you don't want to include this as part of the video, but
We're just special.
if you want to advertise that you'll give your personal cell phone number to all your patients, but whatever it takes. But with us, it was made such a huge difference, and we really can't thank you enough. We'll give you 5 stars on Yelp.
Well, it's my pleasure. I love your family, and we did it.
Yeah,
We did it.
I know. In a few months, he'll get. He really stopped complaining about the braces a while ago, but once he gets them off, he's gonna love it even more. So it's just a few months away, I think.
All right. God bless, and we'll
All
talk
right.
soon.
Thank you.
Thank you.
Take care.
Thank you so much for listening to this. I got permission from the boss. I get extra time. But I wanted to share, I use the word enlightened, and you also don't know so much, so I don't mean to impose that you needed to hear this to be enlightened, but I was enlightened. When I realized that he got his relationship back with his sister, that he had been on behavioral therapy and meds, that he had no friends. Chad, you helped rescue this kid by introducing me to Daniel. And we did this. I told them we did this. My team did this. I'm a small part of this. God did this. Thank you, God. I give you all the credit for this, for the people you put in my life. So I can't emphasize it enough. We did it. This meeting did it. Right? This is a great family, and I'm so blessed to be a part of it. And I'm a part of this family too. Mom and Dad Clower. We did it. Your son helped me do it. And what do we call that? It's a victory, right? We call it a victory, right? So back to Dane, right? I was with Dane in the hospital. I think it was a Tuesday night. He got a lot of bronchitis, breathing issues. And so we thought, get him to the doctor because something was going on. Well, it was an enlarged heart. So he got admitted to the hospital, and Suzanne and I had our routine. She would be with him during the day, and then I would stay the night, and she'd be home with the kids, and then we would switch, right? So we find out he has a large heart. They did an IV in his scalp. If they stuck something in his arm, the tape would come off because the skin sloughed. So they put this line in his head. It was heart meds. And I'm laying on the hospital bed with him, and we're in the NICU, second floor, Good Sam Hospital, just the two of us and a nurse. And at 2 a.m, his IV came out. And he was rustling around, and he woke up, and the nurse came over, and I said, well, I don't know if we can get this back in tonight. It's not going to stick. And so we talked about doing a PICC line the next day. And then Dane sees the TV monitor hanging over the bed, and he says, Dad, I want to watch TV. I said, oh, Dane, we got to get some sleep, buddy. We can't watch TV. He says, no, Dad, I want to watch TV. Please, Dad. Please, Dad. So I'm figuring, what's going to be on the TV in the middle of the night at the hospital? So I turn it on, and it's these beautiful images of the Sierras. It looked like Tahoe. And I said, Dan, I'm going to take you there one day. And he stood up and went into heart failure. And the nurse had walked out, so I'm yelling for the nurse, I'm doing CPR. And they come in, and luckily we hadn't been transported to Stanford yet, so we were close to home, and I called Suzanne, and I said, Suzanne, you got to get here. So she races over. They're trying to resuscitate him. The doctor's in there, and he's not going to make it. And Suzanne grabs his hand and says, Dane, run to Jesus. And he listened. He was always a listener, amazing little kid, and he did, right? And the presence of the Holy Spirit was so strong in the hospital room that I knew he was healed. I knew his skin was perfect. I knew his heart was working perfectly. And what I realized is Dane's okay, and now how do we help the other kids that aren't? And so, we did the concerts, and we raised the money, and we got the Apple money, which was a huge blessing, right? And we got it figured out. It was years after he passed. It was 7 years after Dane passed. We found out what it was. And so Suzanne and I are driving with Kate and Shannon to Disneyland. We're driving down I-5. And we get a call from a mom in Colorado. And she says, is this Suzanne? And Suzanne says, yes. And she says, my name's so-and-so, and I'm a mom, and I've got a daughter who just got out of the hospital. She has heart failure. And because of Dane and the paper, right, because of the index patient, we know what's wrong. And they were able to help her. And that's the message, helping the parents help their kids. And it starts with the diagnosis. And I'll share, I wanted you to hear from those parents because I'm that parent. Suzanne's that parent, right? Driving down to Disneyland with Dane, he loved Disneyland. We stop on the side of the road and we open the minivan so he could get some fresh air, and I'm holding him in the chair with the door open and a couple walk by and they look back at me and stare me right in the eyes. I'm holding Dane. Your kid needs a bonnet. Then we get to Disneyland and I'm holding him next to Small World and a guy walks by and says, put some sunscreen on that kid, right? What do you think David and Sherry heard from the school and teachers? Your kid needs to show up on time. Your kid needs to do his homework. Your kid's being rude to other students. He's lashing out. And nobody could help him. Chad, you rescued this kid. And that's why we're all here.
All right. Well, I hope you enjoyed Dr. Phelps's lecture. As you can tell, a lot of passion and energy went into that presentation. He spent hours and hours putting together that data, and really, really cool to see like real live cases and such. So a few closing announcements. The AACP has launched its Pro Series. It's 16 CE hours. You can do it all virtual. And AACP diplomats and members put together the content. It's great. And I think you'll really find it beneficial. The learning objectives kind of start with basic anatomy, evaluation of the airway, describing evaluation of the TM joint and other anatomical parts associated with those regions, and then demonstration of how to interview a patient and really how to work up a case. So I think it's extremely valuable, great content, and I know a lot of people are looking forward to taking that. And then last little push for the annual symposium. We got some phenomenal speakers. Sasha Gomanak, many of you have heard, but she's kind of doing a 2.0. So she's going to dive deeper into different kind of blood chemistry levels we can look at with our sleep patients. Dr. Miran is going to be doing PRF and a hands-on workshop. Dr. Judy Owens is going to be talking about pediatrics and sleep. Dr. Bob Walker is going to be talking about structural issues associated with the TM joint. Praveen Irani, the PBM laser expert. And many of you know Dr. Peter could be talking about ablative light scalpel uses, tongue tie, lip tie things. Dr. Tenholder, and talking about Orlays, Photona laser, and the 1064 really is what she's going to be stressing on. And the Dr. Tony talking about CO2 lasers and use for snoring and sleep apnea. So we got a ton of great speakers, a lot of hands-on stuff. So get it signed up, get your flights, get the hotel booked, and we look forward to seeing you guys in San Antonio. Thank you.